Hello, welcome to Tala Talks NICU. We have been asked to go over the pathophysiology of persistent pulmonary hypertension of the newborn. So that's what we're going to do today. To really understand PPHN, you have to really get the physiology of the heart and lungs of the baby in utero. So I'm going to start off by just reminding everybody what the general physiology of the cardiac pulmonary system is in utero. So I always draw hearts as a square, so just ignore the bad art. Okay, so just as a reminder to everybody, so we have the four chambers of the heart. So this is the left side and this is the right side of the heart. Remember, when you're looking at an x-ray, when you're doing anything in medicine, you're assuming that that person is pointing towards you. So this is the left and this is the right. This is the left atrium, the right ventricle, and the left ventricle. And then you have coming out of the left ventricle is the aorta, which gives the blood to all the body. And then out of the right ventricle, you have the pulmonary artery, which gives the blood to the lungs. That was actually a pretty good picture of the lungs. So then coming back from the body into the right atrium are basically the superior vena cava and the inferior vena cava. So that's coming back from the body, remember that. And then the lungs send the blood to the left atrium through the pulmonary veins, okay? So that's coming back from the lungs. Okay, a couple of things that I want to go over here. In an adult, every single red blood cell goes round the heart twice. So the blood is coming back from the body. Normally it's blue blood because all the oxygen has been extracted. It goes to the right atrium, to the right ventricle, to the lungs. The lungs give it oxygen. It becomes nice bright red blood. Then it goes back to the left atrium, to the left ventricle, and then the aorta pumps that out into the body. Another thing that I want to go through are the three branches that come off the aorta. The first branch that comes off the aorta is the brachiocephalic. So let's write that in. And then we have the left common carotid and the left subclavian. You don't really have to remember what the names of those branches are. What you have to realize is that those are the first three branches that come off the aorta. So let me just label this aorta here, and this is the pulmonary artery right here. Okay, now let's talk about the physiology of the heart in utero. In utero, the lungs are completely filled with fluid, so they're not doing the job of breathing for the baby, right? Or breathing in the same way that we do. All the gas exchange, the oxygen and the carbon dioxide, that job is done by the placenta. So really, all the blood that's coming back from the body, it really doesn't have to go to the lungs. In fact, about 90% of the blood in utero that's going into the right side of the heart is shunted away into the left side of the body. So in utero, there are two different shunts that exist in the heart or just outside the heart that allow that blood to take a shortcut and then bypass the lungs. So the first one is the PFO, the patent foramen ovale. So that's the PFO right there. Okay? The second one is the Ductus arteriosus, okay? The ductus arteriosus is actually right outside the heart. So it actually is a shortcut from the pulmonary artery into the aorta. And look where the ductus normally arrives. The ductus normally goes and joins the aorta slightly after the takeoff from the brachiocephalic artery. And I'm going to go over in a second why that's so relevant. So in utero, the blood that's coming back from the body is being shunted mostly either at the level of the atrium through the PFO or at the level of the ductus from the pulmonary artery into the aorta. These are considered right to left shunts because they're going from the right side of the heart to the left side of the heart. After the baby is born, then obviously at that point, the placenta is no longer there to breathe for the baby. So the lungs have to take over the job of the placenta. They have to take in the oxygen and breathe out the carbon dioxide. So now we want the blood going from the right ventricle into the pulmonary artery and into the lungs. The way that blood flows in a body is pretty much like fluid flows in any mechanical system. If there is lower resistance, then that blood is going to want to go in that direction. So in utero, the lungs are filled with fluid. And obviously, if they're filled with fluid, then it's going to be under very, very high pressure. So that's why the blood will take the path of least resistance in utero, and instead of seeing this high pressure in the lungs, they're going to be like, okay, well, we'll just go through the PFO or the ductus into the aorta. After a baby is born, that fluid leaves the lungs. And as some of it starts happening before the baby is born, during delivery, and then the crying after the baby is born helps get rid of the last little bit of fluid. With that fluid going away, the pressure in the lungs drops a lot. And so what ends up happening then is the blood that's coming back from the body, even though the PFO is still open, even though the ductus doesn't close immediately, that blood now in the right ventricle, in the right atrium is like, okay, well, maybe I could actually go down here into the lungs because it's taking the path of least resistance. Remember, however, though, that immediately after a baby is born, there's probably still a little bit of lingering pressure in the lungs. And that is why we always want to follow the pre-ductal sat in the newborn nursery immediately after the baby is born. And let me go through that. So the blood coming back from the body is blue blood, because the body has used all the oxygen and extracted it, so the hemoglobin is now deoxyhemoglobin. So this is all blue blood coming down here, right, into the lungs, and the lungs are going to make it nice, bright red blood. Immediately after the baby's born, there's still a little bit of pulmonary hypertension. It's not going to go from being extremely high pressures in utero to suddenly being very low pressures. In fact, that can take several days, it can even take weeks for these pressures to go down. So right after the baby is born, there's still a little bit of shunting, maybe at the PFO, also at the ductus, from the pulmonary artery into the aorta. So immediately after the baby is born, there's right to left shunting. So now let's see, the rest of this blood has now become nice bright red blood. That's the job of the lungs. So this is, I can't get my lid off. Okay, so this has become nice red blood in the lungs. That's not very red. Okay, so it's coming back nice and red into the left atrium, into the left ventricle. Okay, it leaves through the aorta. The first branch off the aorta after the coronaries is the brachiocephalic. So this bright red blood goes to the brachiocephalic, and the brachiocephalic goes off into the right subclavian, which basically gives the perfusion to the arm, to the right arm, as well as to the right common carotids. So that's why this is going to be bright red blood, because it's pre-ductally. It's pre-ductal. So your pre-ductal sats are on your right hand. A lot of the time you can also check it on the ear as well. That would also be pre-ductal. Then after the ductus joins, you've got some of this blue blood that has come across, and you've ended up with purple blood. So the descending aorta obviously goes and gives the blood to the rest of the body. The feet are always going to be post-ductal. Obviously, the femoral arteries are going to go off down there somewhere. So this blood is going to be, this bright red blood is going to be mixed in with a bit of this blue blood. So this blood ends up being a little bit more purple immediately after the baby's born. So pre-ductal blood immediately after the baby is born, the reason why you would expect it to be much brighter red blood and have a higher oxygen saturation is because the pulmonary artery, the pulmonary pressures don't drop immediately, so you still have a little bit of right to left shunting, and the brachiocephalic is pre-ductal. So by definition, every fetus in utero has pulmonary hypertension, in that the lungs are filled with fluid, and so the pressures in the lungs are elevated. After birth, a baby should transition, and the fluid should leave the lungs open up, and the pressures in the lungs should fall down. If that does not happen, then the babies end up having persistent pulmonary hypertension of the newborn. There are many different diseases that result in persistent pulmonary hypertension of the newborn. Most of the ones we see are reversible, things like sepsis or RDS or meconium aspiration syndrome. Some of them are fixed pulmonary hypertension, things like CDH. I'm going to do a whole lecture on the different types of pulmonary hypertension. For now, I just want you to understand the pathophysiology of what happens in the heart and lungs when we do have that pulmonary hypertension. So we already said that after birth, the pressures in the lungs should fall appropriately. And a lot of that happens because the lungs get rid of the fluid. The other thing that happens is that oxygen is a very potent vasodilator in the lungs. So just having more oxygen going to the lungs relaxes all the smooth muscles around the arterioles in the lungs and ends up with dropping the pressures of the lungs further. So the combination of getting rid of the fluid as well as just more and more oxygen going to the lungs decreases the pressures in the lungs. So that's what should happen if the pressures were falling appropriately. However, if there's some sort of pathophys going on in the lungs, whether it's an infection, you've got a really bad pneumonia, or you've got really bad RDS, or you've got meconium aspiration syndrome, where you've got little bits of meconium covering the lungs, then that pressure in the lungs will stay inappropriately high. How do we actually diagnose pulmonary hypertension? A lot of it is a clinical diagnosis. So the first thing that we can look at is the difference between the pre-ductal and the post-ductal sats. So if we have a pulse oximeter on the right hand, which is the artery coming off the brachiocephalic, and then we have another pulse ox on the foot, which by definition is post-ductal. If we see a big oxygen saturation difference between the pre and the post-ductal sat, then we have to assume that the reason why that's happening is because we're having more shunting of that blue blood from the pulmonary artery into the aorta. And you can imagine that the bigger that oxygen saturation difference, the bigger the proportion of that shunt is, and therefore more of that blood is going from right to left. Why would more of that blood go from right to left? Because of higher pulmonary pressures. If these pulmonary pressures were only slightly elevated, then only some of that blood would want to go from right to left. If these pulmonary pressures were suprasystemic, which means that the pulmonary pressures were actually higher than the pressures in the body, then most of that blood is going to go from right to left, and you're going to end up with an even bigger pre to post ductal sat difference. The easiest way to diagnose persistent pulmonary hypertension after birth is that we have a big pre and post ductal saturation difference. That's assuming that the ductus is still open. Obviously, we're going to have some level of hypoxemia. Otherwise, you're not as concerned about having pulmonary hypertension if your oxygen saturations are 100. But if your oxygen saturations are in the 80s and you're having to give a higher and higher FiO2, then at that point you have to start thinking, is this pulmonary hypertension? Ultimately, the way that we diagnose pulmonary hypertension in the NICU most of the time is by getting a cardiac echo or an ultrasound of the heart. In adults, very often they can stick a catheter directly into the lungs and directly measure the pressures in the lungs. We don't really do that in the NICU. So what we do in the NICU is we get an ultrasound of the heart and we look for clues on the ultrasound of the heart that would suggest that a baby has higher pulmonary pressures. So these are all the possible signs that you could see on an echo in a baby that has pulmonary hypertension. So remember that the heart is a muscle. So very logically, just like any other muscle, if you go running and you work out more, it's going to get bigger. So if you think about it, if you have higher pressures in the lungs and the heart has to work against those higher pressures because the right side of the heart is constantly having to pump blood to the lungs. If it's having to pump blood to the lungs, which are under higher pressure, then you can imagine that the walls of the right ventricle, which are a muscle, could get bigger, right? So one of the things that we look for is there any right ventricular hypertrophy to suggest that that muscle is working harder to push blood against the lungs? So that's the first one. The second one is, where is the position of the intraventricular septum? So the septum is the wall between the left ventricle and the right ventricle. Normally, the left ventricle is pumping blood to the body, to the entire body, and the right ventricle is pushing the blood towards the lungs. So normally, the left ventricle is working a lot harder than the right ventricle. So normally in systole, as they both squeeze and pump out their blood, normally there's some level of bowing of the septum into the right ventricle. So normally the septum is kind of bowing into the right, like that. If there's a higher pressure on the right side, then that septum will no longer bow inside the right ventricle. That septum could be flattened, or even in really bad cases, the septum could bow into the left ventricle. So you might see on an echo report interventricular septal flattening, which would suggest that there's increased pressures on the right side of the heart. So that's the second thing that you might see on an echo. The third thing that you might see on an echo is the shunting. So obviously after birth, especially as you expect the pressures in the lungs to go down, you would expect, if the ductus is still open, that there would start to be shunting from left to right. Same thing with the PFO. If on the echo report they say that there's continuous shunting from right to left through the PFO and through the ductus, again, that suggests that there's increased pressures in the lungs, because again, the blood is going to take the path of least resistance. So that's the third thing that we would be looking for on the echo. The fourth thing that we look for on the echo is some level of regurgitation. So you can have regurgitation at the level of the pulmonary valve, which is between the right ventricle and the pulmonary artery, or you can have it at the level of the tricuspid valve, which is the valve between the right ventricle and the right atrium. So as the blood is being pumped out in systole, most of the time, obviously, it will go straight towards the lungs. Sometimes during diastole, where it's not under the same pressure, you could have some leakage through those valves. So instead of it going forward, sometimes some of that blood can actually regurgitate backwards. That again is going to happen when you have increased pressures in the lungs. The cardiologists are able to look at the speed of that blood going backwards, going the wrong way, and determine through a complicated mathematical formula exactly what the estimated pressures of the lungs are. So just to review quickly, the 4 different clues that you can look on the echo to diagnose pulmonary hypertension in newborns: 1, hypertrophy of the right ventricular walls; 2, a septal flattening; 3, shunting from right to left through the PFO and the ductus; and 4, tricuspid and pulmonary artery regurgitation. So how do we treat pulmonary hypertension? Obviously, something is causing the pulmonary hypertension in the first place. So if it's an infection, we have to make sure that we're on antibiotics. If it's respiratory distress syndrome, we should be giving surfactant and the positive pressure that the baby needs. And whatever else is causing it is what we have to treat. But we also have to be very aggressive in as much as possible in trying to get the pressures down in the lungs, because like I said, it can end up in a very vicious circle where the lungs get more hypoxemic, so the pressure gets higher, so more shunting from right to left, so the pressure goes higher, and you can end up in a very, very bad situation where the only way you can get out of it is literally ECMO. So what can we do before we get to that point? Like we said, oxygen is a very powerful vasodilator in the lungs. So these are babies that we should be giving all the oxygen they need. So normally we all know that oxygen can be very toxic to babies, especially in premature babies. But in babies with pulmonary hypertension, we need to try to get those smooth muscles to relax, those arterioles to relax. And so we need to give them the oxygen that they need. So giving a good amount of oxygen to these babies is a very good start. The second thing is INO, inhaled nitric oxide. So that also, and the way that we give that is through a ventilator or through some sort of oxygen mechanism that goes directly into the lungs. We can give it with CPAP or with high flow, or we can give it with the oscillator or the conventional ventilator. And you basically blow nitric oxide directly into the lungs at a tiny, tiny amount, about 20 parts per million. And INO is a very potent vasodilator as well. It will directly work on different channels that will directly relax those smooth muscles and help decrease the pulmonary pressures in the lungs. Viagra or sildenafil is a tablet form or an IV form that works in a very similar way to INO. Normally, we would use that sort of tablet form in more chronic babies with persistent pulmonary hypertension. But immediately, you have a baby who is born recently in the unit with very high pulmonary pressures, you're going to give oxygen, and if you have to, give nitric oxide. So what else should you be doing to support the baby? You can imagine that if the pressures in the systemic circulation are very low, and these pressures are very high, then more blood is going to want to shunt from right to left. So you could make the argument that if we increase the pressures on the left side, so in the body, so increase the systemic pressures, then maybe that blood won't be as likely to shunt from right to left. That's kind of a tricky situation. We definitely don't want to be hypotensive. In a term baby, we don't want mean arterial pressures in the 30s. But if there's a high pressure here, if you're artificially raising the pressures on the left side of the body, and you have high pressures in the lungs, then even though you might not get a lot of shunting, this heart, the right and the left side of the heart, is now having to pump against very high pressures. And that is unsustainable. If the pressures remain elevated both on the left and the right, eventually the heart will fail. So yes, you do not want low pressures in the systemic circulation, but you don't want pressures with a mean arterial pressure of 70, just so that you can make sure that you're not right to left shunting. Eventually, that right ventricle will fail because it is having to push against the high pressures in the lungs as well as the high pressures of the bodies. So definitely you do not want hypotension, but you don't want extreme hypertension either. The other thing that we used to do is make the baby slightly alkalotic. So like I said, oxygen is a pretty potent vasodilator of the lungs. The other potent vasodilator of the lungs is alkalosis, or really general acidosis ends up with pulmonary vasoconstriction. So a long time ago, we used to actively try to lower the carbon dioxide, the CO2 in these babies as much as possible to make them slightly alkalotic. So in that way, that would also encourage the smooth muscles in the arterioles to relax. The problem with that is that it also constricts the arterioles in the brain. So having a lot of oxygen or having alkalosis constricts the blood vessels in the brain. So obviously not great for the brain. So where have we kind of ended up now? Kind of somewhere similar to the blood pressures. We don't want CO2s in the 20s, but we also don't want CO2s in the 60s with these babies. So the other thing that you should be thinking about in a baby with pulmonary hypertension is that these are not babies that you want really agitated or fighting. Because by definition, if they're crying and fighting and grimacing against the tube, that in itself is going to cause constriction in their lungs. So you want these babies as relaxed as possible. And generally, we like to use morphine because if anything, that helps with a bit of pulmonary vasodilation. So, say you've had a very sick baby who has a horrible GBS pneumonia and sepsis, and the pulmonary pressures have climbed and climbed and climbed, and you've stabilized the blood pressures, you've ventilated this kid as well as you can, they're on the oscillator, you're giving oxygen, you're giving nitric, and you've sedated the baby, and still the baby's SATs are getting lower and lower. You get an echo, you see all the bad signs of this baby having suprasystemic pulmonary hypertension, and you feel like you might lose the baby. Do you have any other steps? The ultimate step is ECMO. And that is where you are literally taking all of the blood out of the body and putting it through an artificial lung and maybe artificial heart, and then putting that blood back into the body. And at that point, what you're hoping to doing is just stop this vicious cycle of having hypoxemia, more pulmonary hypertension, hypoxemia, more pulmonary hypertension. Very often, babies with bad pulmonary hypertension that have otherwise good lungs can recover very, very quickly from just having a little bit of VV ECMO, because basically you're just allowing those lungs to relax and you're giving them nice oxygenated blood and allowing them to have a chance to heal. So ultimately, with severe pulmonary hypertension, in lungs that have a reversible cause of injury, then you'll ultimately have to put them on ECMO. So get your baby to an ECMO center. I hope you learned something today. It's a really complicated topic, so if you want me to go over it in more detail or with better pictures, Justin, then I can try to do that. Otherwise, please remember to like and subscribe and comment on anything that you want me to talk about. Thank you.